Hello, everyone. Thank you so much for joining us today for our webinar, How Some Primary Care Practices Are Surviving COVID-19. We have a great lineup today. I'm Julie Shills. I'm serving as your moderator today and will be facilitating the session. For PCC, I am an executive member liaison to the board. I have a counterpart in that role, Rob Driven from Merck. We've been doing this role for quite some time now and occasionally help support PCC and their webinars. A little bit about PCC. It's a nonprofit multi-stakeholder organization that brings together through collaboration organizations that are really focused on both primary care and patient-centered medical home. I work for Mathematica, and as executive member, we are thrilled to participate with PCC. We find that the resources that they provide, the voice they have for primary care is incredibly valuable, and also a very keen and aligned voice to be able to have conversations with CMS as well. So if you are not a member, certainly encourage you to do so. Moving a little bit into some of the housekeeping items, many of you might be wondering if you'll receive the slides. Yes, you will, as well as the recording will be made available to participants. Give the PCC staff a few days to be able to post that on their website. The other thing is all of you are muted so that we can have good audio, but we want to have participation. So in the chat function, if you have a question at any time during the presentation, please feel free to chat your questions into the chat box. With the help of Stephen, Communications Director at PCC, I'll be monitoring that to be able to surface your questions to our panelists. Let's see. A little bit about our agenda. I'll do a few more announcements and introduce our two groupings of both health plans and those who represent our providers and represent providers. We'll have a moderated discussion among the panelists and then also have Q&A from all of you. So as we think about, let me go back one. Oh, really sensitive, sorry guys. Alyssa, maybe you can get us back. There you go. Thank you. When all else fails, ask PCC staff to help. You know, when we think about this topic, really the impact of COVID-19 on primary care has been so incredibly palpable. And furloughs, needing to close offices if practices were associated with more fee-for-service payment, that really impacted their ability to have survivability. So today we're going to hear from our group of panelists talking about how through the collaboration in their states, they've been able to overcome some of the challenges that have been maybe more acute for other primary care providers. In terms of some of the additional support that PCC is providing, they have surfaced a health plan roll call. You can see it on the screen and on PCC's website that really highlights the payers who are stepping up in this process. I think that's critically important to really highlight those best practices and how payers are providing support to primary care during this difficult time. The other component is that PCC, along with the Larry Green Center, as well as X4 Health, has been doing a weekly or bi-weekly survey to understand from primary care how are they coping, what things are they're finding difficult. Is there any support that they've found to be helpful. And a few surveys ago, we added the patient voice as well, really surfacing the need and patient voice around how important primary care has been for them. So really encourage you to look at PCC's website and find those resources that are available to you. So today we have two pairs of speakers, one from a health plan, one from representing providers. Our first pair will be from from Michigan, Blue Cross Blue Shield of Michigan and providers, and then our second pair from New York, CDPHP, and a provider from New York. I will go ahead and introduce our speakers. They've been gracious enough to let me do that really quickly so that we can get to their presentations. But we have Karolina Skrzypek, a physician. She's a medical director of Blue Cross Blue Shield of Michigan. Eva Matuszewski, who's co-founder of MedOne. I've had the MedNet1 Health Solutions, and I've had the pleasure of knowing Eva. She's just been an advocate for primary care for a very long time. We also have Dr. John Bennett, President and CEO of Capital District Physicians Health Plan, CDPHP, and Tutu Adatona, a physician in a practice in New York who has really done some, as you will hear from her, done some wonderful things and for her patients through this crisis. So with that, in the introduction of our panelists, I will turn it over to Karolina.
Hi, everybody. Good afternoon. Really nice to be here. Thank you to the PCC for inviting myself to present on behalf of Blue Cross Blue Shield of Michigan some of the ways that we have adapted as a health plan to support our provider community here in Michigan. Next slide, please. I want to first introduce everyone to Value Partnerships. So this is the department within Blue Cross Blue Shield of Michigan that is really responsible for practice transformation, for convening the medical community, for funding value-based reimbursement, and being an information intermediary. So Value Partnerships is a collection of programs that collaborate with physicians and hospitals across Michigan to make healthcare work better for everybody. It's really a unique type of collaborative model. It uses data collection and also sharing of best practices to really help our health professionals improve patient outcomes. So on this slide, operationally, our foundations are the ambulatory programs, such as our physician group incentive program, which is then interconnected, as you can see, to a lot of the other programs that supports. So one other thing is timely sources of trusted clinical information that drive our value-based reimbursement for physicians, also incentive programs, as well as collaborative meetings. So this is a portfolio of interdependent programs that collectively drive outcomes and really improve the quality of care while also making it more cost effective. Next slide. So the umbrella of our value partnerships programs are, under the umbrella of our value partnerships programs are our physician group incentive program and also our CQI platforms. And these two platforms were very important to our response to the COVID pandemic. So these two platforms have actually been around for quite a while, for about a decade. And because of the strong relationships that they have forged throughout that time period, we were really able to quickly assemble groups of statewide providers and give them a forum for sharing information and best practices. We were told that we were really the only ones in the state who were convening such a group of stakeholders and providers in such a quick period. We were able to accomplish were a rapid dissemination of policy changes, as well as key information to our providers. Some key things that we were able to accomplish were we were also able to gain feedback about what the providers needed. So this wasn't just a way for us to disseminate information, but also to see what our providers' needs were and how we could, better adapt to those needs. Next slide. So through our PG programs, we actually host regular meetings with the provider community. We were doing this even prior to the start of the pandemic. These are usually done on a quarterly basis. And then we utilized that same communication avenue, and we were able to hold meetings for the first few months of the pandemic on an almost weekly basis. At those meetings, we had representatives from the Michigan Department of Health and Human Services. We had key leaders in our state who participated. We have representatives of major private laboratories, as well as our own executives from Blue Cross Blue Shield of Michigan. And we also disseminated communication via our existing PGIP communication channels. So we use those channels to dedicate some, room for COVID-19 so that our providers were up to date on all the changes that were happening. Next slide. So the PGIP, the Physician Group Incentive Program, really has a set amount of funding each year that physician organizations can earn through performance. What we did is we advanced that funding that would have been spent later in this year, in 2020. We also redirected existing physician group incentive dollars to support things like COVID testing and treatment. This was very important. It ensured that our providers had access to funds to buy things such as PPE, as well as to support them in testing. Also, these payments were used to pay providers for care through telehealth visits as well. Next slide. So another example of our response to the COVID-19 pandemic was the redesign that was undertaken of our CQIs, which are our clinical collaborative quality initiatives. So our CQIs are initiatives that address many of the most common and costly areas of surgical and medical care in Michigan. These are both hospital and physician-led initiatives that collect, share, and analyze data on patients. They look at outcomes and then design and implement rapid changes to improve patient care. As we know in healthcare, changes can take a long time, sometimes 10 years or longer. What we've been able to do with our CQIs is actually come up with solutions and then implement those changes within a matter of months. So two adaptations to the COVID-19 pandemic that our CQIs underwent were our MDC collaborative developed hospital-specific resource utilization reports that aimed at helping hospitals prioritize which surgical services can begin again and with the least impact on care of remaining COVID-19 patients. So they were really able to see, which surgical procedures can begin first and how that's going to impact the use of resources so that patients who do have COVID-19 can still utilize those resources when admitted to the hospital. Another change that was made was through our HMS consortium, which is our hospitalist medicine collaborative, and they worked to really quickly identify factors associated with a severe course of illness in our members. They identified these patients' characteristics, treatments that may lead to better outcomes, and they are also working on understanding the long-term implication for hospitalized patients, such as readmissions and other things that may happen down the line for our patients. Next slide. One other thing that we did very quickly is we rapidly deployed incentives to support key needs for a high-functioning telehealth delivery model. So we recognized very early on that many of our providers were moving towards using telehealth platforms and were delivering a majority or starting to deliver a majority of their care that way. So we quickly recognized and acted on that fact. And so our incentives not only support this immediate need, but also encourage a long-term, more sustainable telehealth strategy for our providers. And we see that strategy as being one that also uses things like a HIPAA compliant platform. But initially, we are supporting both HIPAA and non-HIPAA compliant platforms for our providers. And so, as I mentioned, we also wanted to support our providers in the long-term strategy of moving towards HIPAA compliant care delivery. We encourage things like patient-facing applications. So anything that makes the access of telehealth easier for our patients, linkage to the EHR so that there's interoperability and that we can share this data going forward, and also streamlining the telehealth process. So we used funding to rapidly deploy and encourage all these various processes. I also did want to mention that we saw a tremendous uptake, as I'm sure a lot of others have, in telehealth services by our providers. We went from 9% of our PCPs and behavioral health specialists using telehealth pre-pandemic to close to 82% once the pandemic started. Next slide, please. So one other area that I closely work with is our provider-delivered care management here at Blue Cross Blue Shield of Michigan. And we pretty quickly implemented changes to make care management services easier to deliver. First of all, we increased our fee schedule by 20% for our provider-delivered care management fees. We relaxed criteria so that our provider-delivered care management services could be delivered virtually, not only through audio-visual means, but also through the telephone for those patients who may not be able, who may not be as tech-savvy, may not be able to log on to some of these platforms. We made sure that, for these higher-risk elderly patients, they were able to use the telephone to utilize these services as well. We also encouraged the use of our provider-delivered care management to outreach and coordinate for those patients facing increased behavioral needs. So we also encouraged the care managers in our state to outreach those patients who may be isolated, suffering from depression or anxiety. Next slide, please. So just in summary, I wanted to just sum up some of the things that we at Blue Cross have done as a response to the pandemic. So first, the needs of our providers evolved during the several months, requiring our organization to rapidly adapt. And I think because of a lot of the existing channels and platforms that were in place and a lot of the great relationships that have been forged throughout the years, here at Blue Cross Blue Shield of Michigan, we were able to make those changes and adapt and be very agile and flexible to support our providers from very early on. Also, we were able to meet the needs of our providers and help facilitate some of this flow of communication. As I mentioned, we were some of the only people in the state that were bringing together our providers, other stakeholders, and other executives throughout the state to make sure that our providers were getting accurate information on things like lab information, changes that we were implementing at Blue Cross, but also things from our Department of Health here in Michigan. And then I also just wanted to summarize that, those platforms, the Physician Group Incentive Program and the CQI platforms were just invaluable during this crisis. So, those relationships and the fact that those platforms were set up also helped. And then we accelerated payments to support our physicians. We encouraged telehealth by engaging early on with our providers and helping to support them early on during this crisis. And then we were also able to redesign some of our CQI platforms, and also we were able to deliver care management or make delivery of care management services easier for our providers and for our members.
Good afternoon. I'm Eva Matuszewski, and I'm with Medical Network One. Next slide. I'd like to just give you a quick overview of who we are. We currently are approximately 900 physicians. All are self-employed healthcare professionals, also behavior health specialists. We provide infrastructure support to our healthcare community, providing them with ADT access, admission, discharge, and transfer access. We also provide them with a patient registry, and if they are in need of an EHR, we will also provide that access to them. We also provide an entire gamut of multi-specialty, multidisciplinary teams. So if you are in a primary care environment and you're seeking a behavior health person, a dietitian, a registered nurse, we will infuse those individuals into your practice. We have a very large relationship with community behavior health organizations, including CCBHCs, and we are contracted with most payers in Michigan and very strongly aligned for over 10 years with the Blue Cross and Blue Shield of Michigan Value Partnership Program that Dr. Skrzypek referenced earlier. Next slide. And what we've also discovered, because of the funding that we received quickly on from Blue Cross, we were able to expand outreach services provided not only by our physician community, but also provided by the care management team that was affiliated with the practices that we were working with. And it was very difficult initially because we had to survey all of our practices to find out what they had available, to determine where they were located, what they needed. And we wanted to make sure, as we were doing frequent follow-ups of those practices, because we got into the habit of doing that each week, we were able to determine what their needs were and how we could support their needs. And we discovered very quickly the Ides of March, March the 15th, will always be the defining day where we discovered that our practices began not necessarily closing, but they were being challenged because of the lack of PPE. They were already reducing non-emergent visits, and we were finding that things were changing radically in our community. Next slide. So what is it that we did as an independent physician organization comprised of behavioral health specialists and podiatrists and dentists and everyone that you could possibly think of that supports the needs of that patient? Well, we were very fortunate because Blue Cross and Blue Shield of Michigan called and said, we're infusing money into your coffers today. We're going to make sure that you've got sufficient money to go ahead and support the PPE needs of your practices, also provide assistance to your own infrastructure so that you can maintain without really reducing what it was that you were doing. So what we did is we created our own internal checklist. Every Monday morning, we would call the practice to find out what are your hours of operation, tell us about your policies and procedures, tell us about your PPE needs, what is it that we can help you with. As you can see in bullet point 4, most told us we need help with telehealth billing because every payer had a different approach to that. Modifier codes, procedure codes, diagnosis codes. They were desperate for PPE. That first week, we had practices that were clamoring just to get one N95, just to get a box of 3-ply surgical masks. So some of us actually obtained import licenses to be able to pull in PPE directly from China. We also helped our practices with applications. Practices in primary care never had to create business recovery plans. They never had to create pandemic plans. They never had to address business issues because physicians, on the average, do not see themselves as small business owners. The culture had to radically change, and we had to be a part of that massive change. And so the way we did this was constant and consistent communication. We kept asking our physicians, what do you need? The first 2 weeks, we didn't get to talk to the doctors. Strangely, week 3 and 4, we saw a dramatic change in physicians talking to us and saying, these are the areas we need. Next slide. And so in order to support the needs not only of our physicians, but our community and our patients, we developed our own COVID-19 response team. The COVID-19 response team really went ahead and provided additional support to our community-based organizations, our behavioral health organizations, our dentists, our specialists that were clamoring for assistance. Plus, we knew we needed to do something for the patient, for the family or the caregiver, especially with those families that had major challenges with the elder community. So we needed to train practice teams. We already had well-oiled teams, but what about those that were just starting? So we created a physician playbook with the assistance of funds infused by Blue Cross again, and then we reached out to a local organization to develop and share a rather sophisticated but short training video so that anyone who didn't know how to don and doff a mask, put on gloves, how to put a gown on, could view a 12-minute video, take a look at that physician playbook, and be able to actually share that information not only with their own teams but with those outside the practice. Next slide. And so the patient outreach was pretty unique. Blue Cross arranged for us to go ahead and receive an infusion of information We almost knew real time what patients had gone through COVID testing. Well, what do you do with that? Do you call them and say, hey, you got COVID, you're positive? What's the next step is what some of the teams are asking for. Well, what we did is within 48 hours of release from an emergency room or from being tested positive COVID, we would contact that family, that caregiver. We would review the information that they were given, and then we asked questions like, do you have soap? Do you have PPE equipment? Do you have a thermometer? Do you have a pulse oximeter? What education do you have? What kind of additional information do you need? So we actually sprung into action and began packing PPE tools that we were sending out not only to physician practices and others in the community, but to our patient population. Next slide. And so as we began looking at that information, we said, how can we track that? How can we share that with folks? So the bulk of my team at Medical Network One is comprised of MPHs, and they really began to help us look at the trends. They began to say, let's go ahead and link our information to the most recent census report. Let's take a look at our zip codes. Let's go ahead and see how many of the patients that we have additional comorbidities, and review the ED and also review the discharges to analyze the length of hospital stay. Next slide. And so we created a dashboard. It didn't take long for the IT team internally to determine what it was that we wanted to follow. The group got together and we were now able to analyze, and this is not current data, this is simply a sampling. We were able to review gender. We were able to take a look at age. We were then also linking it to all of our primary care practices and then reviewing on a day-to-day basis what area were those results coming from, what hospitals had the greatest readmission or admission rates, how many people we had in ICU, how many mortalities we had. Next slide. And so when you take a look at our COVID dashboard, we were able to drill down to the specific location in the Detroit area. And if you see the large circle on the right-hand side that's sitting on top of Ontario, Canada, you will see that Detroit was really hard hit. But then as we looked at patients by zip, we began to see significant trends within 1 month of COVID becoming a true pandemic in our state. Next slide. So Wayne County, of course, which is where Detroit is located, was truly our #1 hit site. We had very many FQHCs. We had many smaller practices, solo practices that needed tremendous amount of support. We provided them with the support, and we also provided the patients, the caregivers, and the families associated with those practices with the type of support that they needed. And we immediately saw that there was a dramatic increase in the African American community being hit by COVID. Our second community was the Hispanic community, and then we also saw some trickling of the LGBT community being impacted by this. Again, really provided us with a lot of great information that we would not have been able to attain without having admission, discharge, and transfer information real time, without having access to clinical data, and without having the infrastructure created by a care team. I cannot stress enough the importance of having a multidisciplinary team with individuals who already are attached to that practice. Next slide. And this is the last thing I'd like to share with you. So we mailed out over 800 packages to patients and to physicians, and those are individuals. Each one of those individuals may have 2 or 3 separate packages sent. But this is one patient experience. It tells the whole story. A care team member called after the patient was discharged and basically said, what do you need? What can we do to help you? Let's go through the symptom process. Go ahead and recognize what you need to know. And then all of a sudden, that last paragraph, if it weren't for the initial discussion and the educational material I received, I may not have recognized the symptoms I was experiencing were related to COVID. people were so busy that they forgot to care for themselves, and that outreach by a care team member was crucial. Next slide.
John?
Hello. Yep. I'm making sure I've got down here control of the slides. I think I've got it. Thank you, and welcome. It was great listening to that. I learned a lot. You guys did a fabulous job, very detailed and fabulous job. I love your graphics as well, so that's great. Looks like you're serving the providers in Michigan extraordinarily well, so kudos. So I'm here to talk to you a little bit about what went on in the capital region of New York, and I'll start with little bit about who we are, because we're not, people may not know who we are. So briefly, we are in the capital. The capital district applies to the capital district of New York State. So for those who think that all New York State is New York City, we are the capital of New York. And there actually are about close to 1 million people in our immediate region. And we insure about 382,000 of them. So as you can see, we are, a fairly dominant payer here. We are physician founded. We are not for profit. We are mission driven. We have a network model. We don't, at the current time, directly employ physicians, but we have very deep relationships with our physician community. As you see here on the slide, we don't only operate in the 4-county capital region. We operate in 26 counties in upstate New York, and we stop short of New York City, and we stop around Syracuse, and we go all the way pretty much to the border. So that's who we are. I want to talk a little bit about, I know the topic is COVID, but I think it's very important to realize that our response to COVID, particularly on the primary care side, was really colored by our enhanced primary care program. We have a nationally recognized patient-centered medical home model where our primary care network, some 95% of it now, is on a global payment model, or it's not technically capitation because it's not full risk, but it is a global payment, and it is risk adjusted, and it has a significant quality component. We've been doing this now for over a dozen years, and we've been very successful in transforming these practices. We have good data showing quality improvements and lower total cost of care. We took the approach that we would pay doctors for better, not more care. And when we started it, really over 12 years ago now, our goal was to, as our physician majority board, and I was the board chair at the time, this was before I left clinical practice, said, we have to save primary care in the capital region. And even if we don't, save any money, we have to save primary care because our mission requires it, and the quality that the residents of this region deserve requires it. That said, we started out by having several cornerstones. We obviously followed the basic model of patient-centered medical home. We quickly realized that just checking those boxes was totally insufficient. And we really embarked on major practice transformation, and that was entirely funded, by CDPHP. And we took kind of an all-payer model. In the original people who participated in the pilot, although we picked practices, although we picked practices that had a very high penetration of CDPHP patients, and it's easy to do that, particularly in our core. We have many primary care practices who have upwards of 50, 60% of their practice are our patients. We took kind of an all-payer model, and then we realized you can't transform only part of a practice. We linked that with payment reform, and we relied very heavily on interoperability. We provided funding sources for people to, particularly smaller practices, to acquire EMRs. We gave them incentives. We gave them direct payments in the form of grants, and we did everything we could to make them, on top of that, as interoperable as possible. And we also helped them hook up to our regional health information organization. New York State has publicly funded Health Information Exchange, which has been reasonably successful, and so we helped them with that. And with regard to the payment model, the global payment model is risk adjusted. We started off with some kind of proprietary risk adjustment models. We have subsequently moved to the CMS HCC model. And one of the things that we found was that our model resulted in on a fee-for-service equivalency base, a reimbursement that was 40% higher than people would obtain on fee-for-service. Plus the opportunity to earn 20% of a bonus, which was originally tied to triple aim goals. We subsequently moved to total cost of care on a risk-adjusted PMPM basis, and are now moving on to a true MLR model. Again, this is not full capitation, but it is based on, but the bonuses are based on MLR for their population. And we have some practices that are very large, where they have many thousands of our attributed lives. And one of the things we've done with some of the smaller practices is actuarially roll them up into groupings so that they become actuarially significant. We've also done this across all lines of business. We do participate in all fully insured lines of business, both commercial and Medicare Advantage and Medicaid managed care, as well as the Affordable Care Act exchange. So we realized that practices needed to treat all their patients the exact same way. So with that baseline, and of course, as a physician's health plan, we have had a very robust, I was really happy to see the physician engagement division that our friends in Blue Cross in Michigan have. We came up with the same title, and I started that, again, about a dozen years ago. And so we have an entire physician engagement unit, which reports up to our chief medical officer. And so with that, we started a very similar campaign. I won't go into all the details, but we meet with these practices very, very frequently. We're a regional payer. We have smaller numbers. A lot of our communications is, as I did with Dr. Adatona, who you're going to meet in a minute, is I just call her and said, "How are you doing? What do you need?" And so then we did whatever, we helped her, as much as we can. But I'm trying to advance this. So at the beginning, from a medical practice standpoint, we had a lot of priorities when COVID hit. Of course, our first was to make sure we could, go virtual and continue to pay claims and answer the phones and do all that. And we did that, and our people have been working virtually now for several months. But the point of this presentation is to talk about particularly protecting our independent practices, our practices who are not part of a larger health system or a hospital system, people that are in the trenches that are taking care of patients and that have to live on their own dime. So we're very, that's who we are. That's who started us. That's our culture. And so we reached out to providers. We have a number of ways to do that. We have an EPC collaborative group. We have frequent meetings with them. We accelerated those meetings. We have an independent specialist group because, again, in most communities, 2/3 of the physicians are specialists. They're not primary care doctors. We wish it were the other way around, but in America, it's not. but we reached out to them through our independent specialist group. We accelerated our meetings. We had bi-weekly meetings. We created a team of people here at CDPHP who looked at everything from and assessed all the things that were mentioned by the prior speakers, everything from payment. We created an advanced payment program with, it says zero interest loans. I mean, it wasn't technically a loan. We just gave them the money and we'll figure out how to settle up later. There were no loan documents. It was very easily done. And we had an algorithm for how we could do that, how we could reach out to them. Remembering that in the primary care side, since these patients are these practices are getting fixed payments on a risk-adjusted basis with our capitation imputation model, they didn't see any decline in payments. So their payments were the same. So with the primary care practices, we didn't really have to do that. We only had to do it with our specialty practices, some of whom were moving off fee-for-service, but most of whom are still on fee-for-service. So we did that. We obviously very quickly waived cost share for all COVID-19 testing and treatment. We very quickly paid telehealth and particularly mental health telehealth, which is a particularly good story, at parity with in-person visits. We're going to have to decide what we do when this crisis passes, and it will pass. It's not going to be here forever. And we very likely will continue that parity. We haven't made that decision yet, but we think we need to stimulate the continued use of telehealth, particularly on the mental health side, where it's really been, we've had a lot of mental health providers. Not only, the stress of the pandemic has created, increased need for behavioral health services, but it also, since a lot of these behavioral health practices are small and independent, was very stressful for them. We got a lot of practices who increased their productivity with telehealth dramatically. I've always felt that telehealth needs to be one of the things that medicine in America has is it's not very. There's been no increase in productivity of the individual physician, and that's why the unit cost continues to rise. And so I believe that telehealth is a tremendous opportunity to increase the productivity of the individual physician. And nowhere did we see that more evidently than in the behavioral health side. So I think that's a very powerful thing that we'd like to take advantage of when this is over. And we can talk about that if there are questions about that. So there was a lot we did. It worked well. We have not had, failures of independent primary care practices in this region. Knock on wood, we haven't. I would know if we had any. We haven't had any. And we're also finding now that the telehealth visits are starting to drop, and we track them daily, and we had meetings about it. And now what's very interesting is what we don't want to do is lose the momentum around telehealth that we've gained, because and it's also, the thing I'll say about telehealth is that it's more than just an episodic acute visit for a cold or a sore throat. It's really about how you use digital medicine as a platform to also manage chronic disease, so you almost get somewhat continuous care. And so we're very interested in the future in looking at partnering with our provider groups as to how we can do that. As I said, we do partner with a lot of our practices. I'm going to take this opportunity now to introduce Dr. Adatona, and let me just describe her a little bit and brag about her a little bit and embarrass her, as I often do. One of the things that I'm very proud of, and we're very proud of in our community, is, practicing medicine is very hard, right? And doctors are burnt out. Well, my answer for burnt out doctors is Dr. Adatona. And Dr. Adatona practices in Lansingburgh, Troy, a community which is very old. Troy is a very old city in America, and right now the Lansingburgh section is economically not in the best shape. She has a practice which has a very heavy Medicaid population. She has a practice which has a very heavy CDPHP population. since we are the major Medicaid managed care payer in Troy and in Albany and in Schenectady and in Saratoga. And one of the things we're particularly proud of, we do a Top Doctors Award, and it's based on your quality, service, and cost efficiency metrics. And we rank the doctors, and we celebrate it, and we have this thing. And Dr. Adatona is one of our repeat winners. She's always near the top. She's wins, or she comes in second. And, you know, it's kind of like, you know, the golf pro who, you know, wins the tournament, and they're always in the top 5 or 10. And I think that's particularly instructive because, again, she's a solo practitioner. She has only 5 employees. She has a low-income community. You know, all those things I said. That's where it's supposed to be, you know, really hard to get high quality, high service, and lower cost. And this gal knocks it out of the park. And I think that gives me hope that medicine doesn't have to only be huge practices owned by hospitals, which I'm not a fan of, and it doesn't only have to be huge corporate medicine, that there is a role for the human touch and the individual solo practitioner, which is so important and we're losing in this country today. So I'm going to turn it over to Dr. Adatona, and she's going to tell you a bit about her story in COVID. So thank you.
Thank you very much for inviting me this afternoon, and Dr. Bennett, thank you for the introduction. I'm just going to share with you what I did during COVID. What I did during COVID is not actually just unique to COVID. On the slide, can
you do it?
Yeah. Sorry, I'm just waiting for my slide to come up. Okay. So one more. Okay, so really this is the recipe for the success in lasting family practice. So all the above 4, quick decision making, continuous analysis of processes, patient access, business sustainability. This is what I have in place before COVID, during COVID, and is still ongoing after COVID. This is the platform that I've always used. So what happened during COVID? I remember the date was March 12th. COVID had been brewing for a long time. Everybody being scared, everybody being careful. I've been thinking about it, writing journal every night. I came into the office, I think it was March 12th, and I decided that for the safety of the community, safety of my patients, safety for everybody, I needed to stop in-office visits. So going forward, I just turned on telehealth. And how did I turn on telehealth? It was a question of calling the vendor, signing the contract, sending it back, and just switching it off. Practice for maybe about 1 hour, make sure that everything was okay. I was able to do this quickly in the sense that I wanted to introduce telehealth into the practice, but the only way I was going to use it was that when I'm away on vacation, I'm able to call into my office, because often when I'm on vacation, I call into the office, they send me portal messages. But I wanted to create another platform that I could actually connect with my patients. So it wasn't something new, but it was the first time of using it during COVID. So when I make decisions and have things going, because I'm a solo practitioner, I'm able to see how this flows. Is it compatible with what I want? Am I achieving my aim? Are my patients okay with it? Am I okay with it? If I'm not, I'm just able to just make that decision and bring something else on. So essentially during COVID, that was what happened. So from middle of March to end of April, it was all telemedicine, 100% telemedicine. Like I said, I always assess decisions that I've made to make sure that it is working for everybody involved. As April went along, I think to myself, what's going to happen to my patients with chronic diseases? What's going to happen to my pediatric population? Worried that if I don't keep up with the immunization, what's going to happen? Because recently, maybe a few years ago, there was outbreak of measles. I did have some patients that had measles then. So can you imagine having infectious outbreak on top of COVID that we're trying to contain? I decided then that come May, I'm going to open my practice to pediatric patients, at least for the physical examination. How did I do that? I have an EMR. I ran the list of patients who were due to have the physical done. We reached out to them, booked the appointment, told them what was going to happen. In all this, we changed the patient's flow. There's no more waiting in the waiting room. You needed to come at the time of your appointment. If the people in the office, you wait in your car until the place was open for you to come in. So we're just being careful about preventing the spread of COVID, just in case there's a potential of coming in. So while that was going on, I was thinking about my patients with chronic diseases. What am I going to do with them? I can't leave them behind. I decided to start off with patients with high blood pressure and diabetes. The same thing, went to my EMR, printed out the list with my ICD code of patients with high blood pressure and diabetes. Reach out to them. If you didn't have blood pressure monitor at home, I sent blood pressure monitor to the pharmacy. If you didn't have glucometer at home, I sent glucometer to the pharmacy, talk to you over the phone how to use it. So that was how I started opening up to seeing patients. That is the transformation that has been going on in the practice during COVID. Then by May, I opened up my practice to both adults, children, and I was still screening patients that are sick. I still see sick patients, but I need to screen and make sure that your risk for COVID is low. So that is what we're doing up until now. The key thing as well is patient access. I'm a physician. All physicians out there. The key to success is your patients will have to have access to you. You cannot shy away from patients. You can't run away from patients. You got to do what it takes to see patients. And the art of medicine is that human touch, the human feel that you can't get. I'm not knocking telemedicine down. Telemedicine is great. I've used it. I love it. But there's another aspect in medicine in which is that patient contact. You feel a patient when you're in the same room with them. Body language matters a lot that you don't get on the telemedicine platform. So how did I create the access? It was important to me that I was working towards a platform that was going to get my patient back into the office to start seeing me. I kept in touch with my patient through portal messages, telephone, televisit, everything it took, I did, just to make sure that my patients, they have access to me. So with all that in place, the business aspect of it was also going okay because I still have patients coming in. The revenue was still coming in. And the other thing was that when COVID started, I decided that I looked at everybody around me. I have a small staff of 5. It's really like a small unit, a small family. And I'm also a mother of 4. I've got 2 children that are in the workforce. And one of the things I was thinking during COVID, and I'm still thinking, is that I didn't want them to be followed. I didn't want their hours to be cut. So I needed to do that for my children, for the people working with me as well. So, and there was no question in my mind I was going to cut hours, follow anybody, or reduce their pay. Luckily, I have a contract with CDPHP, which is like the capitation, the money, the income from that was steady. So that gave me no worries. Secondly, they also paid the incentive early. Usually we'll wait until towards the end of the year before you get the incentive, but this year they started paying the incentive earlier. So that also helped a lot. I also have in my practice behavioral health, which is collaborative care for mental health. My practice is structured in such a way that I study my patients. This is what you call population health. I know the need of my patients. I decided the need for my patient at some stage was mental health. So I looked at everything and decided to bring behavioral health into the practice. This helped tremendously. It was available during COVID, the need for it such high, like everybody has said earlier on before me. So that also kept us going. I applied as well for the PPP, which came through, the EIDL came through, and also I had revenue coming in steadily from the patients that I was seeing either through in-office visits or through telemedicine. And that is exactly what I have been doing. That is what I'll continue to do, and analyze the processes at every given point. Thank you.
Thanks to all of you. I think you really highlighted the power of having payer-provider partnerships and really that support for independent primary care practices. We've known that for a long time, but you highlighted that in a crisis, it became that even more important. We're close to the end of our time, so I think I'm going to offer maybe if each of you in the order that you gave your presentation, if you just had one point of advice or something about the next thing you're going to be looking at, if you could just share that with the group really quickly, 30 seconds or less, just share. We'll go through our line of panelists and then close out for today.
So I'll go first. We are going to continue to work on our telehealth strategy and how we can, support our providers using that, as well as behavioral health. I think both of those are really important topics, especially with the current environment for our providers as well as for our patients. And so I think we as an organization, our focus will be heavily placed on those two things.
Great, thank you. Eva?
So from our perspective, it's going to be helping all of the practices develop pandemic plans, develop their own small business continuity plans to ensure that they have a 30-day PPE supply.
So this experience, I think, has just made us realize that we need to accelerate our integration with our physician providers on all levels.
I'm just going to work on balancing between telehealth and inpatient visit to my office.
Well, I think all of you have exhibited, just a tremendous amount of intuitiveness related to how you're responding to the pandemic. You certainly represent not letting a crisis go to waste, already thinking about the next opportunity, and I very much appreciate that you put in the center your members and patients as you proceeded in this work. So we'd like to thank everyone who has joined us today. I'm sure you found the presentation as valuable as I did, and thank you to all of our panelists for giving up of your time and sharing a bit about what helped you to be successful. Also want to thank the PCC staff. They're always such wonderful staff members, creative and great to work with as well. So thank you to everyone.
Thank you.
Thank you.
Thank you, everybody.